Dr. Ross, who I completely respect, was very clear in his report yesterday that we need to look at the way we remunerate emergency room physicians, and we intend to do that. And we are embarking now on a process to negotiate a contract with the emergency room doctors here in the Capital District Health Authority. But we understand, I'm not naive, and this government is naive, we understand that those negotiations will have implications for emergency rooms all across the province. And that's everything I'm going to say on salaries while we're embarking down a process of negotiations with the emergency room doctors. I will say that we completely respect the work that these men and women do. They're valuable in our healthcare system. We are so pleased they're here, and we want them to stay here. And we understand that they have families, and they've worked really hard to get to be where they are. So I can't at this stage with absolute certainty say that the $3 million emergency room protection fund will be used in, this way. We will look at it kind of on a case-by-case basis for initiatives that make sense to help us stabilize a situation in a community while we are building a better system. We have to get to a better system. I think Dr. Ross was very clear as well that putting your finger in the dike over here can create pressures over there, and we have to stop doing that. We need to plan for an entire system, and that is what I'm hoping we will be able to do. The initiative, the Emergency Room Protection Fund, is there to assist communities, and communities are district health authorities operate on the community level. They're there to assist district health authorities, in the work that they do in terms of trying to provide stable emergency room coverage around the province. And we will be open to hearing any innovative and interesting idea that they might bring forward to help us look at how you might do that. I want as well to correct the number. I said 35. I thought we had 35 emergency rooms. We have 38.
Thank you. The Honourable, the Leader of the Progressive Conservative Party.
Thank you. You spoke about the distribution of doctors, and I remember a statistic. I just want to confirm if it's still accurate that per capita there were more doctors in Nova Scotia than there were in a lot of other provinces, perhaps many provinces across Canada, and the issue was with distribution and where they had chosen to work. I guess I see some heads nodding. Can I take from that that statistic is still true?
The Honourable Minister of Health.
Yeah, I think generally speaking it is true. Mr. Chair, when I was first elected, we did have a serious doctor shortage in the province of Nova Scotia. There was no doubt about that. 12 years ago, we had a crisis in oncology in the Capital District Health Authority. There were, virtually 3 oncologists. It was unbelievable, the number of specialists. And we've had from time to time some shortages. Anesthesiologist comes to mind. That's been a difficulty. Some very high, high functioning specialties and specialists from time to time. But for the most part, we haven't had the same kind of situation around GPs that existed 10 years ago. Last year, the Capital District Health Authority recruited 18 new family physicians. But the closest to that is 5 new family practitioners in Cape Breton, in the CDHA. You can see the difference. 18 family practitioners in Metro, 5 in Cape Breton. It's a challenge. It's a challenge to bring people into rural practice. Now, we have many, I think, advantages in our province, and one of the advantages is that geographically we're not that big. Halifax is not that far from an awful lot of places. So in fact, if people really want to, have the lifestyle that they get in a larger metropolitan area, they could still live in Halifax and have those things, but work in other parts of the province. People travel all the time for their work, and the radius of Metro is getting larger and larger, I think. And so we need to think about this. We need to think about people, if that's how they're going to choose to have their family life, their personal life. Perhaps we need to think about what we can do to support that, but to get their travel pattern to other regions to make sure that those regions aren't underserviced. We haven't done that great a job in some parts of the province being able to recruit and retain. You can recruit people, but you can't retain them. And I haven't seen the numbers, but I would think that retention in those areas is probably our biggest problem in some ways, with some exceptions. You look at Antigonish, it's like they have a huge number of family practitioners who, you can't get them out of there with, a crowbar, really. People are just, they love it there. And many people are from the area as well, but they have a nice mix of physicians who are, third and fourth generation Antigonishers, and people who have moved there, gone to university there at St. Yves maybe, on to Dalhousie, back to the area to practice. There are parts of the province that have a very stable family practice population, and there are other parts of the province that have been challenged with that. And I tend to listen to people who have more experience and expertise in this area than I do, and I put Dr. Ross in that category. He, his view, and it was expressed in the report yesterday, is that, if any of us are under the illusion that health, human resources, and particularly doctors and nurse shortages are going to stop being a feature of our healthcare system, we're dreaming in Technicolor. That is a feature of what we're living through. We will continue to have this, especially if you look at the demographics. And in many respects, we are much better off than many other places in the world, and indeed even in the country. I think our numbers stack up quite well regionally and across the country in terms of the number of doctors we have per capita. And earlier this week, I had an opportunity to speak with Doctors Nova Scotia, and we were talking about we were talking about a whole variety of issues, including attracting doctors to the province and retaining doctors here. And it was interesting because the view of Doctors Nova Scotia or certainly the people I was talking to who represent Doctors Nova Scotia, said, you know, we have no concerns about the number of doctors in Nova Scotia. We're not telling the department and the government that, you know, we have a doctor shortage. That's not, you know, we've been through that. We know what a doctor shortage looks like. We don't have a doctor shortage. That now what we need to be doing is we need to be thinking about proper deployment, you know, getting the right person, providing the right service in the right location. And these are the issues that we need to be addressing now. And I couldn't agree more.
The Honourable the Leader of the Progressive Conservative Party.
Thank you, Mr. Chair. And I would like to draw from what you said that what has happened over the last 10 years, which would have been under our government, that we've gone from a doctor shortage to having perhaps the best ratio that we could get. But the challenge, as you've stated, is deployment, distribution, and having your GPs and having your specialists and having them in the right place. And so it's nice that one part of that has been solved, and now the next challenge is to get them in the right place. I do want to move on to another topic, another budget line, I guess. That is certainly not emergency room closures, but it's certainly related to emergency rooms, and I don't think we can separate the two. And that has to do with the rapid assessment unit, and you've talked about some dollars for that. My understanding of that, but I'm asking for clarification, my understanding of that is that this is to improve the patient flow when they come into the emergency department through to admissions, and I know that's all connected to the availability of beds within the hospital to accommodate those patients. And you know, we hear the stories of people, and we've experienced it here at Capitol with people who arrive by ambulance, but moving through the emergency department through that whole assessment, and then getting, once it's been deemed that they're ready to be admitted, and then getting them moved out into a bed. So I guess for clarification, is my understanding of the rapid assessment unit a way to try to facilitate that movement through the system, and if so, how?
Thank you. The Honourable the Minister of Health.
Thank you very much, Mr. Chair. When I was in the Cape Breton District Health Authority, I met with, I was taken on a tour of the regional hospital, and Dr. Curry, who is one of their emergency department physicians, was there, as well as one of the other team leaders, who is a nurse. And it was really, I have to say, it was really invigorating talking to these people. I just felt great after I talked to them. They were pumped, is the best way to put it. And the CEO who was accompanying me told me that 2 years ago in that emergency department they could not find people who would stay and work in the emergency room. It was a demoralized staff. It was, you know, it was the worst place that they had in their facility to try to keep people working. And this has just totally changed. And they have adopted a number of initiatives that have contributed to this change. Now, people want to work on that unit. They have the lowest rates of absenteeism. You know, anyway, they were really excited, and they were really pumped, and they wanted to tell me all about what it is they were doing. And, well, you know what it's like to have these tours. You're there for 15 minutes. You're whizzed from one location to another. You're meeting people. It all becomes kind of a blur in a way, and you're trying to take it in. The one thing I really remember was the rapid response unit that they do in Cape Breton. the Rapid Assessment Unit and how it works. And it just sounded so sensible as well. So when people come in, they have this team of people who are assigned to do this, and they see somebody very, very quickly, and they make a determination about what is the right place for this person to be, and they get them there. They get them there as quickly as possible, and it just clears the halls of the emergency department. And it's been really successful in Cape Breton. So again, one of the things that we made a campaign commitment to in the election was to open hospital beds that would help patients stuck in overcrowding emergency rooms flow through. And so in this budget, for the coming year, we've allocated in the Department of Health's budget $4,318,000 to be used in a number of ways. And we haven't worked out all of the details of all of the ways yet, but we do know that one of the things that we will do is we're going to establish a rapid assessment unit and open 8 additional medicine beds in the Capital District Health Authority. Now, one of the problems with and this is not the only problem with the Capital District Health Authority emergency room, but one of the problems, as I understand it in very layperson's terms, first of all, when that emergency department was built many, many years ago, it never really had the capacity to serve the kind of population we have here in the metropolitan area, and that was at that time. And our population has really increased quite significantly. It's in a teaching hospital. The emergency department is in a teaching hospital which has no general medicine beds. Beds are primarily allocated to along specialty lines. So you come into the emergency department and you don't fall necessarily into any of those specialty lines, or you have some kind of a chronic condition, you're diabetic, you have hypertension, you're asthmatic, you're having breathing problems, you have all of these things going on. Who sees you? What specialist consult do you require? How do you move a person like that in do you send them to, cardiology? So, and try to get a consult from a specialist up on one of the other floors who is seeing their own patients, who they have, had admitted, they've had surgery, whatever. It's hours before somebody is able to come down. This is a very serious problem for the emergency room doctors. They're very frustrated about how they can move people through so they can see all of those folks who are sitting on ambulances lined up in the bays trying to offload their patients. Meanwhile, those ambulances have come in from all over the province, meaning that out there across the province, you have issues around covering those areas in case there's another difficulty. So we really need to provide in the Capital District Health Authority, and Dr. Ross's report spoke to this yesterday as well, that you can't have a province-wide emergency room system that works if you don't fix the QE and deal with the problems of getting people through that system with greater effectiveness and efficiency. So a rapid assessment unit would allow for just that, the rapid assessment of people coming in and a determination of what the situation is and where they best should be seen. And of the $4 million that we have in this budget, that cost of the rapid assessment unit would be approximately $2 million of that. So that means that we're left with the possibility of some other initiatives as well to free up bed space. And we have a number of things that we are still working through, we have to look at. As the former minister knows, we have complex cases. We have people who are in our acute care facilities whose situations are so complex. They have needs that are higher than can be accommodated in a small options home. They may have challenging behaviors that are beyond the ability of a long-term care facility to deal with them. A whole variety of issues. So we are looking at what we need to do with respect to complex cases, particularly where there's mental health problems, and as well as perhaps some other chronic diseases. And so the additional $2 million will be allocated to do a number of initiatives around the emergency room, particularly in the capital DHA. And the rapid assessment unit will be one of those things.
Thank you. The Honourable, the Leader of the Progressive Conservative Party.
Thank you, Mr. Chair. The situation that the minister described, what exists in the emergency department at Capital was very accurate. It was the way it was described to me back in January of last year. And it was the situation and the frustration of Dr. Ross that prompted him to do the Code Orange at that time. And at that time, I met with the CEO and with Dr. Ross to try to understand the situation and to look at what some possible solutions might be. And I was told at that time by the CEO that there were some procedures that needed to be changed, that needed to be addressed, that needed to be implemented within the Capital Health. And they were outlined by the CEO for me at that time. And I believe the implementation of that new procedure was to begin February, March of 2009. My question is, were there any new practices and procedures put in place in order to respond to the circumstances and the situation with moving patients through? And if so, will the new assessment centers be in addition to those change of practices? So I guess the question is, were some practices put in place, and is this an extension of that? And with the combination of the practices and a new assessment center and the new beds, will that address the problem?
Thank you. The Honourable, the Minister of Health.
Thank you very much, Mr. Chair. I don't know if this will really address the member's question, but if it doesn't, she can pose it to me maybe in a different way. We were here back in the fall seeing a lot of code census at the emergency department, both in the Dartmouth General Hospital and at the Queen Elizabeth Hospital. It was hard to really understand what exactly was occurring, I think, in some ways. Our department was in very close communication daily with the Capital District Health Authority, trying to understand what exactly was going on. And, in my mind, I was very concerned about what this meant for H1N1. we were, you know, we're always concerned about what's going on in the emergency room, but given that we were in a pandemic, I was very, very worried that it seemed extraordinary that day after day after day, we had this code census occurring. And as the member knows, code census was the system that the Capital District developed after the Code Orange as a way to prevent, you know, that level of frustration and difficulty from building in the emergency room to try to get the attention of people outside the emergency department that they needed to provide some relief and support to the emergency room. So we have code census, and code census, while everybody thinks it's a terrible thing that a code census is called, it actually is kind of a call to everybody in a facility to harness their resources to free up space to move people, to assist the flow through the department. I've been in constant contact with the Capital District Health Authority Board and CEO about what plans they can put in place to deal with the code census situation. It's not going to help. And they have been working very diligently to develop a plan. They have a person who has been recruited from another part of the country with a great deal of experience in terms of patient-centered care. And she has been working hard to bring people together who work beyond the emergency department to impress on them what needs to happen, excuse me, in terms of opening beds up, making it possible for people who are in emergency room to move through. And they have presented a plan to us very recently, and we will be monitoring the implementation of this plan and the outcomes of the plan. And they will have some additional financial support to do these particular things, the rapid assessment unit. We're also looking at establishing a 13-bed, I can never get these acronyms, IMCU. They are medical ICU beds, and that will allow for people to move much more quickly.
Thank you. The Honourable Leader of the Progressive Conservative Party.
I'll do some talking and you can have a drink. One of the things that was explained to me at that time, and I'm sure the Minister understands, with respect to the movement of patients through the system and into the beds, of course, has to do with the assessment when they come in, the fact that it is a specialist teaching hospital, and also the fact that it was once they get through that, there was still an issue with bed availability in the hospital, and part of that bed availability, after people had been assessed and had been determined that they would be an inpatient, was due to the fact that many patients in the hospital were in an inappropriate setting. They were people who were ready to be discharged from the hospital, and they were waiting placement in another facility other than a hospital. And so that compounded it again, because once you get the emergency room and emergency department issues kind of addressed, and the flow of patient is easier, then you come up against another hurdle when you don't have an in-bed for that patient. And one of the things that we had recognized was the need to have more long-term care beds available across the province, and thus, you know, the initiative to build new facilities and try to move people out of hospitals into a more appropriate setting. So I guess my question would be, and we can talk specifically about capital here. My question would be, once we get the assessment process facilitated and patients can move on, do we still have the challenge of people in hospitals using beds that when they should have a more appropriate setting and be out of the hospital? Is that still a challenge with capital?
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair. Thanks for the break on my voice. No, it's okay. We still have 4B over at the VG, the alternate care unit there. And like your colleague, the member from Argyll, I look forward to the day when there's nobody left on that unit, when we're able to close it. And I actually think we may be moving in that direction at some point in the not too distant future. This is very much a difficulty everywhere. Being able to get people into long-term care from our acute care facilities. There are quite a few reasons why we're unable to do this. Earlier today during the estimates, I had a chance to talk to about this issue with the honourable member from Hants West, who was talking about long-term care, and I was explaining why it's very important for us to be able to devolve long-term care into the district health authorities. When we complete that work of getting long-term care under the district health authority administration, I'm hoping we will see a more seamless process of being able to plan for discharge from an acute care facility into a long-term care facility. And really, that's what the whole process is designed to do. It's to make it a more seamless transition and allow us to be able to move people more rapidly and more appropriately. If you have DHAs with the ability to do better planning around long-term care, around home care, around respite care, all of these kinds of things, we should see improvements in the time it takes to move someone from a hospital bed into a long-term care bed. We aren't there yet in terms of the service agreements with the various long-term care providers around the province, but we will definitely get there. We have to devolve that part of our healthcare system into the DHAs to make it a more seamless system for people. We also, I think, need to do a better job of providing programs in the home. I know that around the province, we have this program now called Hospital in the Home that provides people who want to be at home and who can be at home, but they need, a hospital bed because of their mobility. They can't get in and out of a bed easily. And there's a danger of falls at night and these kinds of things. The Red Cross has a fabulous program of providing hospital beds around the province to people who are in this situation. This is supported by the government and by our department. There are many, many things that we can do to augment and support the long-term care sector and our aging population. The caregivers program that the honourable member from Clayton Park was referring to the other day, you know, is a good example of being able to provide support to you know, people who are a caregiver for an elderly person or a person with a disability or, you know, some condition that requires that they not be on their own. So I think that there are many supports and many things that we have that can be improved upon. Our hospitals need to be hospitals, though they're not shelters, they're not hotels, they're very costly, expensive places, and you know, we need to make them as efficient and as effective as we can.
Thank you. The Honourable Leader of the Progressive Conservative Party, her time has expired on this round. Chair will now recognize the honourable member from Halifax Clayton Park.
Thank you, Mr.
You have
Chair.
approximately 3 minutes.
And there are 3 minutes left. I was finding it very interesting listening to the concerns around moving people into proper care, whether it be back home with the right supports or into a long-term care. I want to switch tracks and ask the minister about page 1316. The bottom of that page has a line item called diagnostic and medical equipment, and that line item was underspent last year by $2.5 million, and this coming year is budgeted to be another, well, in fact, about $6 million less than it was last year. It was budgeted at $26.7 million. This year it's budgeted at $20 million. And I'm very interested in this because I know that equipment and diagnostic equipment and new tests and tools are so important for early detection of disease and accurate diagnosis. And I know that we have a lot of old equipment, so there's got to be a lot of pressure in the system through the DHAs to talk about, you know, how they can acquire new equipment, how they can replace aging machines. Yesterday, the minister will remember we had quite a good discussion around the mammography, new diagnostic machines to do mammograms, and that's very important. You mentioned the DHAs that were now going to be funded with the new digital machines, and we should actually give a vote of thanks to the people of HRM who together organized that big event that the minister mentioned yesterday, Bust a Move. They raised $1 million, I believe, and that was the cost roughly to get us a new machine here in HRM. So that was one part of it, but actually you said the mammography was covered in last year's budget, so that doesn't even affect this coming year. And I want to know what other equipment there is that we're looking at, and I particularly want to know why the budget is down when I'm certain that the stress is very great in the hospitals. They want to replace and have newer equipment. I know a few years ago when the discussion here in the House was around the need for new MRI machines, we actually found that quite a few of the existing ones, in fact right here in HRM where we're actually a teaching hospital, we're training radiologists, and the MRIs we were using were 10 years old. They were really old technology. So I don't think the minister is going to be able to answer my question today, and my time is just about up, but I'd like to leave the minister with that question for the start of our discussion on Monday morning, or I guess it's Monday afternoon. Thank you very much. My time has elapsed, so the chair is telling me we have to be finished, but I was just saying to the minister to please start there on Monday.
The time allotted for debate in Committee on Supply has now expired. The Honourable, the Government House Leader.
Thank you, Mr. Chair. I wish the committee to now rise to report progress.
Is it agreed? Agreed. Motion carried. please. Okay, we're on. Order, please. The chairman on the Committee on Supply reports.
Committee's made progress and begs leave to sit again.
Carried. The Honourable, the Government House Leader.
Thank you, Mr. Speaker. Mr. Speaker, that concludes the government's business for today, but we beg leave to meet again on Monday. The hours will be from 4 p.m. to 10 p.m. And after the orders of the day daily routine, we will continue debate on Resolution 1 that I believe was adjourned by the member from Kings West, and then after that we will go back into supply. So we do now rise.
Thank you. The motion before the House is for the House to now rise and meet again on Monday between the hours of 4 p.m. and 10 p.m. Is the House ready for the question? Question has been called. All those in favour of the motion, please say aye. Those against, motion carried. The House stands adjourned until 4 p.m. on Monday.